Top Med Talk. Hi, it's Monty Mythen here, Editor-in-Chief of Top Med Talk, coming to you live from my home in London, in England, with the first of our series on COVID-19. This is a clinician-to-clinician set of conversations from the front line of colleagues who are trying to deal with the global pandemic of coronavirus 19. I was lucky enough earlier on today to catch up with Professor Mike Irwin, who's Professor and Head of Department at the University of Hong Kong. Now, part of working from home, as many of us are doing between our clinical duties at the moment, we have to deal with equipment that we may not be completely familiar with. So an enormous apology to Mike that during the wonderful interview I managed to record my voice and not his. But we'll get back to you, Mike, and record another conversation with you. Mike very generously had just finished a case in the operating room in Hong Kong. The University of Hong Kong is on the island of Hong Kong. And as we all know now, Hong Kong is part of China. They share an immediate border with China, and China is where the first outbreak of coronavirus 19 was thought to happen in Wuhan. Now, I asked Mike about their early experiences with the outbreak of COVID-19, and very reassured by the fact that based on their previous experiences of SARS, they actually seem to have had things relatively under control. So he described the fact that although they're seeing cases of COVID-19, what they've seen so far in his hospital has been in the tens, not the hundreds, and no one in his hospital has yet required intensive care. And they are months into this outbreak now. I asked him why he thought that might be. Well, he said that based on their previous experience of SARS, which they were hit really badly by in the past, that not only is the system very well prepared, but the people, the population, are very well prepared. So they immediately take actions that we are trying to get people to adopt in the country of England now, to self-isolate if they're unwell, to distance themselves from social activities, to use the appropriate occasional use of masks, hand washing, hand hygiene, all those things that we're told that we should be getting on with. He told me that they kick in pretty immediately there because the last time they were exposed to a probably more lethal virus, and SARS, they saw deaths in previously fit and well people, along with what we're told at the moment, the exposed population of the elderly, the frail, and those with comorbidities. I asked him if we could be too prepared for this, because we seem to be putting a lot of resource into preparedness at the moment. We are telling each other that we're preparing for the worst and hoping for the best. And as reinforced by everyone I've spoken to about this so far, he said, no way, you can't be too prepared. So they have done all the things that we're either thinking about or have done now in our various countries. They've suspended elective operating in their hospitals. They've ramped up their critical care capabilities. They've closed universities. They've closed schools. They're distancing themselves, and they're saying, well, we've been here before. Let's get through this one again. I asked him if they were screening elective cases for COVID-19. He told me that was not the way they're approaching this at the moment. If somebody appears to be well, they continue with the universal protections we're all supposed to adhere to and appropriate use of the more advanced personal protection equipment. But largely speaking, it's business as usual from that perspective. So I went on to ask him, based on his previous SARS experience, whether when things quieten down, as they seem to be happening quite quickly now with the caseload dropping in both China and South Korea, for example, whether it is the sort of period of time we can expect until we ramp up to normal activities again. And he said, well, based on previous experiences, it's months as opposed to days and weeks. I also asked him how it had been affecting his life personally, and he said, well, young kids, they're off school, they're tearing the place up. Everyone has concerns about older children, those who are going for exams, and how it might affect their education long term. But everyone's kicked into using online support, and basically stay at it, we can get through this. He gave me a personal experience from being on the tube in Hong Kong about 2 days ago, and said it's very interesting to note that in a highly densely populated country like China, and in particular Hong Kong, which is notoriously densely populated, that on the tube people were distancing themselves, almost everyone was wearing, if not everyone was wearing a mask. Now there's a debate whether that's appropriate or not. And they're very limited touching, and if they were touching handrails, etc., immediate hand sanitization. I think our experiences on the London Tube at the moment are quite significantly different to that. So all that, I think, from the point of view personally reassuring that all the efforts that we're trying to put in place in our various countries do appear to have a very significant impact on containing the spread of COVID-19. Now, he says he's suspicious that it has spread through the population, and we did touch a little bit on the debate about so-called herd immunity, but by taking these measures, they haven't seen the enormous numbers of critically ill patients that has been seen in parts of Italy, for example. So here's a conversation we recorded yesterday with our colleagues. It really is the sort of sharp end of the Italian experience. Now, it's quite a long piece, so may have an initial listen now, but I strongly advise you to take some time to listen to the whole thing. It's quite emotional at times. It's quite a scary story, but balancing that off with the Hong Kong experience, for example, and I promise Mike will loop back to you and get your own voice in this in the days to follow. But let's have a listen to our colleagues in Italy. Let's have a listen to a conversation led by Mirco Nacoti, an intensive care specialist from Bergamo in Italy, right in the front line of what's considered to be Europe's epicenter of COVID-19.
I just come back from San Giovanni Bianco. It's one of the little healthcare system in a part of Bergamo. And today I showed some healthcare system in Bergamo because a reporter of help me, Maurizio, Mark come from Wall Street Journal, is going to do a reportage about the situation. And so I try to show him the main problem that, in my mind, we found with this epidemic situation, because this epidemic situation, in my opinion, is like an Ebola. You have to think that, because you have to be fear. If you don't look the fear on the eyes of the people, that means they are not prepared. Because it's not Ebola. Ebola is a big lethality, but when you have a thing that a big lethality, probably the spread is not so high. You can think to the SARS. SARS make 3,000 deaths in the world, and people waited the SARS several months, but the SARS stopped in China. The first case of COVID in China was the 8th of December. The Chinese people was very efficient, because in 3 weeks, from 8 December, 31 December, they found 20 cases, and they speak that about WHO, and WHO make the first communication to the healthcare world system. So after 3 weeks, the virus was identified. And according to the data of the Chinese population, because Chinese population, in my opinion, tell us everything. If you read the epidemiological data, the virus is 10 times more contagious of the SARS. The virus has the same viral load in the asymptomatic and symptomatic patient. That means if you are asymptomatic, you go around and you can infect every people. But I don't know why in my hospital, no one read the epidemiological data about Chinese population. The people work and they don't know the epidemiological data. They don't know that probably the children and the child are dangerous because they fall ill very few. They are often asymptomatic, and probably they are the main carrier of the virus. We have actually in the hospital 500 cases of COVID. Our hospital is the hospital of reference of the Lombardia region, of the Bergamo, sorry, is the town with 1 million people. So it's the main hospital where we do everything, transplantation, we treat children with any pathology. And the hospital has 900 beds with 70 places of intensive care unit.
70 beds in your intensive care unit?
Not in mine, but in all hospital, because we have the general intensive care, the neurological intensive care, and we have also 18 beds for children from 0 to 18, excluding the neonatal area. Now, you have to imagine that we have 500 patients with COVID in the hospital, 500. And the most of the people has critical situation. In a normal situation, that people should be in critical area. But they cannot stay in critical area because all the 70 places, all the 70 beds of intensive care are occupied by patients that have the more severe case of COVID, the more severe case of respiratory failure. So the hospital is totally paralyzed and is totally contaminated. So actually, if we receive a pregnant patient, because the pregnant patient have to give a baby, and there is no space, the clean space, to allow a sure cesarean section or a sure delivery. If we receive a child with appendicitis, we have to do surgery, and we don't know if the operator or the anesthetist are asymptomatic colonized operator. And this is the situation of the central hospital. And the main message is, when you have a real epidemic situation and nobody in the world, in the rich world, have experience about that, it's not enough an epidemiology knowledge developed in USA, because in USA nobody see an epidemic situation. You have people that can have experience to work in a country where an epidemic situation destroy everything. I try to explain my chief, but it's very difficult, and they laugh me. Epidemic situation is not a pathology. The pathology is a clinical manifestation, but epidemic situation is a social problem. You have social problem that increase the spread of the virus, allow the diffusion of the virus, and maintain the diffusion of the virus. And we have no vaccination. This is the problem, because when you work in humanitarian situation, you do a survey with the normal epidemic situation, polio and measles, and you do survey because it's very important to detect the first case, the first cluster about infection diffusion. You detect and you start a big vaccination of the population. But we are not in this situation. We have not vaccine. So the only thing that you can do is to survey your population. And I think it's not a useful survey the ill population, because the clinical doctors, after 10 cases of COVID, they are expert, because the clinical picture are very typical. Everybody know. Also a taxi driver after 3 cases is a super medical doctor to recognize this problem. But the main problem is to avoid the diffusion. The main problem is not the mortality, is that this virus destroy your system, because there is a long period of asymptomatic pathology, because you have a lot of people asymptomatic but with colonization. And there is at least 15 days that the people seems normal, but the virus is inside them.
Monty Mythen here. On the basis of the fact that you thank you very much for all of your work. I'm really sad that you're under such pressure there at the moment. What do you think we should do to have some lead time, whether that is Andrea in Naples or us in London or Mike and Desiree in the USA? What would you advise us to do over and above what we're trying to do at the moment, which is to put measures in place to try and slow the spread of the disease?
So, first of all, you have observed your epidemiological situation. When you observe one case, or when you observe one death, probably you have at least 1,000 people with the virus, because the lethality of the virus is very low. When you see the data of the WHO, but this is the reality about all the epidemic situation, you read only the confirmed case with diagnostic tool. In this case is the PCR, RNA PCR. But it's very important to know the denominator of this problem. And if you read the literature, actually, after 3 months of the epidemic situation, you don't understand what is the denominator, because there is no important study of survey. I don't know why. But if you read New England, if you read JAMA, if you read Lancet, you cannot find the denominator. But if you like to know your virus, you have to know the denominator. But this is true also for your infection in your PICU department. It's not enough to know the case. It's important to know the case as a tax, and it's important to know how many people develop the pathology, how many people are asymptomatic, how many people colonized, developed pathology, developed severe ARDS. If you know that, you can planify your intervention. If you don't know that, it's impossible. The same thing is for your...
So do you think that testing is very important then? Because there is an ongoing debate about whether we should be testing more people to determine the denominator.
I'm not an epidemiologist, but you have to do cluster study. You have to do cluster study in your health worker population, because it's important for you to understand how many people that work with you are colonized, are healthy, because it's very simple to know the ill people. But the problem are the asymptomatic people, because they go around for many time. After 1 week, they fall ill, but the virus circulating 10 days before. In these 10 days, the virus go in all departments, in all services, and your hospital is in the garbage. So the main thing is to prepare your hospital, you have to see the video of management of Ebola virus, and we can learn a lot. If you see the video of the Chinese population, of the Chinese health worker, you can see how they work. They are not crazy. They are not crazy. They are working in the correct way. We have changed mind, because if you treat the COVID virus as an infarct, as a stroke, you contaminate your hospital.
Yes.
So you have to think in any time, when you move, when you dress anytime, you have to ask yourself, I'm doing something that can contaminate the context? This is the main question. Before to ask, how can I treat this patient? There is a million of everybody now publish how to treat this patient, how do you do, ECMO, everything. That's not a problem. It's an acute respiratory failure. So you have to do everything that you do with the other respiratory failure. That's not the problem, this. You are able to do that, but you are not able to think with the epidemic mentality.
Let me ask you, Mirco, I know that you said this once before, but I want to make sure that it's clear that as far as the patients that you are seeing and that are ending up in, acute respiratory failure versus those that have kind of tipped over the edge and have died, what are the age ranges for that? Is this mostly an elderly patient issue, those for over the age of 65? Are you seeing this in younger patients? And is it looking like the same sort of disease process for both of those types of patients?
Thank you for your question. So also for that, if you read the paper published by the Chinese population on the JAMA, you can really understand everything. So most people are old. The most people have comorbidity. Obese people are very frequent. Is the major population with respiratory failure, and 60% of the ill patients are male. We don't know why. 1% of the population are child, but the most part of these have severe comorbidity, and the most people that die are old people, 40, 50%. And this is true. But this is true when you have an epidemic situation under control. When the situation is over control, everything is wrong. Because if you have 1% of mortality with 100 infected population, we have one death. If you have 1 million of people, 1% is very high. And this is might happen. This is what happened in Bergamo. Bergamo actually has, the city has, Maurizio.
120,000 people.
Okay, thank you, Andrea. According to the study of Lancet, the Chinese estimation tell us that the coefficient that explain the capacity of the virus to develop is in the big contaminated area 2, 3. That means that in this moment, the contaminated population of the Bergamo is about 60%. And this is true. I have no data, but I see 500 people intensive care in my hospital with COVID. And all the hospitals around Bergamo are full about COVID patient. And what happened now? We have it's too much. It's too much, and we have good experience in treating this patient, but in normal situation, in the epidemic situation, the supply is less. There are a lot of people that are treating patients without experience in intensive care, because 500 is a terrible number. So the people die more.
Mirco, do you and your colleagues know if you have had COVID-19? Do you know if you've been exposed? No. Okay.
No, because the
testing capability is not there, or
we did a lot of testing, but the testing are only for ill patient to confirm the case, and the staff is not testing. That's the problem. Why that? Because you can test everything. We receive 100 patients per day, and in our hospital, and the microbiologist developed the test for all the hospital around Bergamo. They are doing 1,000 tests per day. So it's an hard work. You have to choose people ill or staff. What do you choose in epidemic situation? This is an important question for an epidemiologist, not for an intensive care doctor. You don't know nothing about that. The intensive care doctor intube the patient, manage the respiratory failure, but have no experience about epidemiologic situation. The main mistake that you can do is to develop an intensive care approach of the COVID. If you do that, you destroy your hospital. You know what I mean?
I do. I see your point. This is very, very helpful. Thank you.
I think this bad experience may help people to understand that the model of patient-centered care cannot resolve all the problem of the population. We have to give power to the territory, to the peripheral situation. All the rich countries are developing this type of system, but this epidemic situation have to learn us that this is not the good model, because in Bergamo, all the peripheral, all the context around Bergamo now are isolated because the system is destroyed. And the system in the last 20 years developed a centralized system, reducing more and more device, doctor, and everything in the area around the town. And now we have no the possibility to treat these people, and we have to learn that. We have to give power to the community. In this situation, I treat people in hospital, in peripheral situation, and most people, this is an important clinical question. Most people, when has fever, probably develop very early hypoxia, day by day, and nobody detect this. And after 10 days, people arrive in hospital without energy because they breathe 10 days without oxygen, maybe with 80% of oxygen. When I went in the home to take patient, I discover 80% of oxygen, and the people did not seem very, very ill, but the saturation is very low. For me, this means that if we bring the oxygen at home, if we treat them with telemedicine, we leave the virus at home. We do not diffuse the virus. Every people take your virus at home and develop your antibody. Every time when you take the patient, you bring in the hospital. After that, you bring in the other hospital because the patient develop a severe RADS, and so you bring in the other important hospital. All these are vectors of the virus. Every time you move the patient, you move the virus, and you contaminate other people. This was, I think, the main problem in Bergamo. I had a wonderful system of transport of patients from home to hospital. When a people has an heart attack, in 30 minutes is in the hospital, and we do angioplastic, and we save a life. But you imagine, virus, people call, I don't breathe, ambulance arrive, people without any DPI, take the patient, bring the patient in a hospital, arrive in the hospital, valuation, no, the patient is so severe, it's better to transfer in the other hospital. So when the patient was in this hospital, was not put in a special area because no people at the beginning thinking to COVID. So the patients stay in the waiting area, the parents stay in the waiting area with other parents, and every action was contaminated. Mm-hmm. And you have to know that the people that transfer the population, the driver, in the night go at home. At home, they found a sister, grandmother. After that, go in the bar, in the restaurant, and after 15 days, they are ill.
Yeah.
But in these 15 days, they meet 100 persons, and each of these 100 persons meet 100 persons. You know what I mean?
Mm-hmm. Yeah. Yes, Mirco. Again, thank you so much. This conversation has been enlightening, and I really feel like a lot of what you've talked about are lessons to be learned and to be taken for us to put into practice. Thank you so much for all of your time. I hope that we can speak to you in the days and weeks to come, and you can give us some updates about what is happening there in your community, Mirco, and you will be sharing your words with the world. So thank you so much.
Top Med Talk.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.